Unlike Cushing's syndrome, adrenal insufficiency is a serious pathologic condition characterized by decreased production or action of glucocorticoids and/or mineralocorticoids and adrenal androgens. Adrenal insufficiency can be categorized into two types depending on the locus of the pathologic lesion causing the disorder: the primary adrenal insufficiency or Addison's disease, and the secondary adrenal insufficiency. Primary adrenal insufficiency, also called Addison's disease, is a rare condition that only affects 1 in every 10,000 people. However, it affects people of all ages. Particularly, it occurs when the adrenal glands are damaged and can't make adequate hormone cortisol and aldosterone caused by autoimmune diseases, such as type 1 diabetes, vitiligo, hypothyroidism, and Graves' disease. Other causes, including bleeding in the glands, infections like tuberculosis, and genetic diseases. One is congenital adrenal hyperplasia, and surgical removal of the adrenal glands. In contrast, secondary adrenal insufficiency, far more common type of AI, results when the pituitary gland, a small gland near the brain, does not signal the adrenal glands to make cortisol. Some causes of secondary AI may be temporary, such as taking certain prescription medicines like prednisone, hydrocortisone, or dexamethasone. Other causes may be permanent, such as pituitary tumors, pituitary surgery, or radiation damage to the pituitary. The difference between primary and secondary AI is that people with Addison's disease produce a high level of ACTH but no cortisol, while people with secondary adrenal insufficiency have absent or delayed ACTH responses. Before discussing the pathophysiology of adrenal insufficiency, let us have a quick review on the anatomy and physiology of the endocrine system. Specifically the hypothalamus, pituitary gland, and adrenal gland. Hormone production mainly starts in the hypothalamus, a small region of the brain lying below the thalamus. Below the hypothalamus is the pituitary gland. The pituitary gland is divided into two lobes, the anterior and posterior lobe. The hormones produced in the anterior pituitary circulate into the bloodstream and act on distant target organs, particularly the adrenal gland. In the hypothalamus, a certain hypothalamic hormone called CRH produced by the paraventricular nucleus. CRH is released and travels to the pituitary gland via the hypophyseal portal vein and then positively targets the cell called corticotroph in the anterior pituitary to release alpha MSH and ACTH. Now, let us focus on ACTH. ACTH then travels to the adrenal glands via the bloodstream. As we all know, the adrenal gland is mainly divided into two parts: the adrenal cortex and the adrenal medulla. ACTH positively acts on a bunch of cells, especially it targets the adrenal cortex. The adrenal cortex is the outer region and the largest part of the adrenal gland. It is divided into three regions: the zona glomerulosa, zona fasciculata, and the zona reticularis. ACTH stimulates all these three cells. The zona glomerulosa secretes mineralocorticoids or aldosterone, which is responsible for electrolytes balance, especially sodium and potassium. The zona fasciculata secretes glucocorticoids or cortisol, which plays an important role in cell metabolism, regulation of blood glucose, immune response, bone formation, and sleep-wake cycle. Third, is the zona reticularis secretes gonadocorticoids or the androgens, which act as a precursor to make estrogen and testosterone. On the other hand, the adrenal medulla, the inner part of the adrenal gland, controls hormones that initiate flight or fight response. It secretes epinephrine and norepinephrine. These hormones are capable of increasing heart rate and force of heart contractions, increasing blood flow to the muscles and brain, relaxing airway smooth muscles, and assisting in glucose metabolism. However, when cortisol levels are high, it can cause negative feedback on the hypothalamus, causing it to produce less CRH and the pituitary gland to produce less ACTH, which shuts down production of steroid hormones in the adrenal cortex. Over time, this lack of stimulation can cause the adrenal cortex to shrink or become atrophic. The pathophysiology of adrenal insufficiency depends on the pathologic lesion causing the disorder. Again, we have here the hypothalamus and the anterior pituitary gland. The hypothalamus secretes CRH. The CRH then stimulates the anterior pituitary to release ACTH, ACTH acts on the adrenal cortex, which produces steroid hormones as discussed earlier. In the case of Addison's disease, the immune system attacks the outer portion of the adrenal glands, specifically the cortex. Why does this happen? One is because of mutations in the autoimmune regulator or AIRE gene, making the adrenal glands to have antibody receptors that attack 21-hydroxylase enzyme. This enzyme particularly required for the production of aldosterone and cortisol. Without this enzyme, the cortex cannot produce enough steroid hormones, resulting in low aldosterone and cortisol levels. Another thing, AIRE gene eliminates self-reactive T cells that would cause autoimmune disease. The autoimmune destruction of the steroid-producing cells in the adrenal cortex results in low steroid hormones. Deficiency of aldosterone causes electrolyte imbalance such as in sodium and potassium. It causes the body to excrete large amounts of sodium, resulting in low sodium levels or hyponatremia. What happens when the body's sodium levels are low? Blood volume decreases, resulting in low blood pressure and tachycardia. Because of lesser blood travels to the heart muscle, so there isn't much for the heart to pump out. The nervous system automatically increases the heart rate to get the blood pumping, and thus tachycardia occurs as compensatory mechanism. In addition, low aldosterone causes the kidney to retain more potassium, leading to high levels of potassium in the blood or hyperkalemia. Cortisol deficiency increases cell sensitivity to insulin, resulting in dangerously low blood glucose levels or hypoglycemia. Furthermore, cortisol acts on the pancreas to decrease insulin and increase glucagon, and it is known to be an insulin antagonist, which means it inhibits insulin's ability to lower glucose levels. The deficiency also prevents the body from producing carbohydrates, which are required for cellular function, as well as protein, which is required for fighting infections and controlling inflammation. This causes muscle weakness and weight loss. Deficiency in gonadocorticoids cause loss of libido, amenorrhea in female and erectile dysfunction in male. Now, what happens to the hypothalamus and pituitary when there is a low level of cortisol? Instead of a negative feedback loop, the hypothalamus releases more CRH, which causes the anterior pituitary to secrete more ACTH in an attempt to stimulate the adrenal glands. What causes hyperpigmentation? The corticotrophs in the anterior pituitary are stimulated by increased CRH to release more alpha MSH and ACTH. The melanocytes are targeted by alpha MSH, which causes them to create more melanin. Increased melanin causes dark pigmentation of the skin and mucosa. Generalized hyperpigmentation is a hallmark and most important differentiating feature of primary adrenal insufficiency from secondary adrenal insufficiency. In addition, when the adrenal glands are destroyed by infection or cancer, the adrenal medulla, and thus the source of epinephrine, is also lost. However, this loss does not cause symptoms. Other causes of Addison's disease are cancers that has metastasized and medications that can interfere with steroid synthesis enzymes like ketoconazole. While in secondary adrenal insufficiency, mainly caused by the lack of CRH produced in the hypothalamus, pituitary adenoma, and medications that lead to less production of ACTH. Without ACTH there will be no stimulation of the adrenal glands to produce steroid hormones, leading to deficiency in aldosterone, cortisol, and androgens. Addison's disease typically manifests as a gradual onset of nonspecific symptoms, which mostly leads to a delayed diagnosis. The symptoms may worsen over time, making early recognition hard. In many cases, the diagnosis is made only after the patient experiences an acute adrenal crisis. This could be precipitated by a stressful illness or other triggering factors such as infection, trauma, surgery, vomiting, or diarrhea. ACTH stimulation test is the most specific test for diagnosing adrenal insufficiency. Blood cortisol levels are measured before and after a synthetic form of ACTH is given by injection. Low cortisol and high ACTH levels indicate Addison's disease, whereas low cortisol and low ACTH levels indicate secondary adrenal insufficiency. If the patient tests positive for Addison's disease, the healthcare worker will determine the cause by measuring the 21-hydroxylase antibody level and performing imaging studies of the adrenal gland. Same as for second AI to detect pituitary tumors. The patient at risk is monitored for Addisonian crisis, which is characterized by hypotension, rapid weak pulse, tachypnea, pallor, and extreme weakness, as well as they're at risk for circulatory shock because of inadequate blood flow resulting in damage to body tissues. Therefore, physical and psychological stressors must be avoided. For the management of Addisonian crisis, immediate IV administration of fluids, glucose, and electrolytes and replacement of missing steroid hormones are needed. Also, careful monitoring of vital signs, weight, and electrolytes status is essential to assess the patient's progress and return to a pre-crisis state. Lifelong hormone therapy with glucocorticoids like prednisone, as well as dexamethasone and fludrocortisone for mineralocorticoid replacement, is used to treat Addison's disease. Men with Addison's disease do not require androgen replacement because their testes can produce adequate testosterone levels. However, women can benefit from androgen replacement, such as DHEA, because the adrenals are the primary source of androgen production in women. Steroid medicine is also used to balance the level of steroid hormones produced by your adrenal glands in secondary adrenal insufficiency. You may also require hormone therapy for the rest of your life. Thanks for watching.